But the next topic will tell us is good or not. It is wrong. It's my honor to introduce this speaker, my mentor, and I'm proud of be his student because he's very famous in the world. Dr. Chyi-Long. I think everybody knew him, so it's not necessary to introduce. So let's go.
Thank you. Thank you for kind introductions. So today, thank you for your join us. And I think my talk about the importance of the standardizations of the radical hysterectomy. And also we want to introductions of the mitral study a little bit. Okay, so I think you will all think these pictures include the 2015 Beijing annual meeting 16 in Taiwan, the president, the Chai also hears, and 17th in the Okayama, Japan annual meeting. All the meeting has more than 3,000 participants in this meeting, and 2018 in Surabaya, and it's also a very popular, and 19 in Chongqing last year in Chongqing. And also this year we will postpone to the meeting to the December because of the coronavirus. I hope all of you will join us, and I hope that in that time we are able to travel all over the world. Yeah. And so another is I want to introduce about the GMIT. The journal you have submit a lot here. So the impact factor is about the 0.7, and so I expect they can be into the SCI next years, and now it's in the ESCI already. Okay, so we just talking about the why and what is the standardizations and the process of the implementing and the developing technical standards, and it should be based on the consensus of the different party, and the consensus will come from the good outcome and the easy way and very convenience to the users, and so they can have the maximize the compatibilities and the interoperability and the safety, repeatabilities of qualities, and also fascinating to the commoditizations and the formal custom process. So it's the standardization is to in the event or an instrument or this something is very important for that. But why we need standardizations in the laparoscopic radical or the radical hysterectomy? Because of it's a very outstanding the paper here from the New England Journal of Medicine. She's talking about the minimal images have an inferior in the outcome than the open surgery. The overall survival have a 96 versus 99 in the open surgery. So in this time, they have an immediately response from various society, include from the European Society of Gynecology Oncology, and the guideline have changed. And they say the current ESGO recommendation regarding the approach for the radical surgery for the cervical cancer, minimally invasive is favored before, is no longer valid, and should be removed and replaced by open approach is a golden method or golden standard. So immediately the ESGO changed their mind. According to the LEC study, they change from the minimal invasive is a favored way change to is not allowed to do this. And the APAGE, our society, we found they have so many bias. So we have the statement immediately to say, no, not true. We hold different opinions because the performance of the surgeon is not standardized. And there are so many reasons. So we hold different opinion in here. And another is that just like Dr. Wang have talking about, the convert rate just very low. And the Dr. Huang has talking about the in lab 2 have a 25.8, but in the radical surgery just have a 3.4, 3.5%. It means it's the image cancer surgery is much difficult than the radical surgery. I think it's not true. Everyone know about that, but they have conversion rate just have a 3.5. We found it, and also they find it that the performed is not qualified surgeons. So Dr. Huang is also mentioning about that. So our APAGE have a hold another opinions. So how we find that is not a good study, that the study help by us. So that's the reason our society hold the different opinions for that. Because we know that every research or study, they thinking about the interesting questions and shall we have an open or minimally invasive therapy? And we have to formulate the hypothesis. Then we say maybe open is better, and MIT will be a better, or MIT is better that because of the small one and the recovery good. So we say that will be better. So we can have a comparison between two, but we should under the equal baseline. So in this problem, AGE, APAGE, the all will be question for that. So we can find the German Society of Gynecology and OB/GYN, they find, they say, we don't believe it because they just have about they did not have the equal baseline. Why they did not have an equal baseline? They're talking about because they have a fewer than 20% of the patient was treated in center of North Americans. So all that is treated in the not so good country. Maybe you're thinking about in South Americans, in India, in China, in Australia, in Italy, and Bulgaria. That is not so like in the North Americans. So that is not fair for this study. So in the later on, the Dr. Upper from the University of Michigan, they proposed a study that is a retrospective study in 815 patients in 9 institute. They all in the United States, in the very famous university hospital, including Duke University and North Carolina, Wisconsin, and Ohio, of the Oklahoma, and Oklahoma, and McGill, he is from Canada, and from Pittsburgh, and the Florida Hospital, and the Michigan Hospital, and the South California Hospital. Always a very famous the university hospital. So the data from the 9 institutes, they have opened just about the 30%, and the 70% is doing the minimum invasive therapy, and the 90 of them is doing the lobar, and just have a 10% doing the laparoscopic surgery. So, and how this outcome, we can find all the age, race, all the body mass index, all the figure stages, grade, all the histologic findings, and also the tumor size. They are quite no difference. But finally, they find minimum invasive therapy, they have a worse recurrence-free survival. 90 versus 92 is a significant difference, but no difference in the overall survival. Disease-free is have a difference, but not difference in the overall survival. But interestingly, we can see the margins they have to. They just have a 0.9 centimeters in the open surgery. They just 3 millimeter to 12 millimeters. And also in the minimally invasive therapy, also the 9 millimeter is from the 4 millimeter to the 12 millimeter. And so recurrence there is quite different. So from this study, we can find it why actually that is the concept. It's not because of the doing the surgery in the United States or in Canada or in China or in Indians. Because of the concept is different. We can see that the vaginal margin is just a 0.9 centimeter. That most of them maybe just the 4 millimeters, and the largest one is 1.2 centimeter. So you can find doing the radical surgery, actually they really don't meet the criteria for the radical surgery at all, because they doing the surgery. Even in the AVH, we can get the 4 millimeter vaginal margin very easily. So they told them that it's a radical surgery. And moreover, no one may think about the parametrics or paracopian margin. No one mentioned about that, because they never mind about the paracopian or parametric. Even they have say, oh, they have got some positive on the parametric, but no one mentioned about the size. But today we have mentioned about Dr. Ball have talking about what is very important in the parametric and paracopian. When you dissect the ventral portion, lateral portion, and the dorsal portion of the parametric and paracopian is a very crucial the resection of the tumor. So why? How come? That's the reason we judge this one by the surgical mark. They don't care about that. And Dr. Wang has also mentioned about that. There has no significant difference, but we can find the recurrence that you just using the type 1 meso 24% of recurrence, and the type 3 have a 13%. Even they have a trend of recurrence rate is quite different. So your radical surgery is same turn as ours? Maybe it's not the same. You say that's a radical surgery, but really it's not a radical surgery at all. So neither because of MIT or the Center of in the North Americans is will have this matter, but the concept. So we can see the German Society of the OB/GYN, they say because of the center, not in the North American. Actually, it's not the reason. It's because of in the Western country, in the North American or some fields, they are not concerned about the radicality, and they are not concerned about the concept. So we note the result is not only the baseline should be attestable. It should be found out if the data is not consistent with the most or all the available data. Now the data is quite different, but you say the leg study is right, so every data is low. I just the leg is right. So we check the data that is published in the literature. Here is from Harvard University, from the so-called Massachusetts General Hospital, and also Brigham Women's Hospital is a very famous one. And they make conclusions. The overall survival rate and the rare recurrence and the frequency of the pelvic lymph node dissection or posteriorly, we can find they did not compromise the outcome. So from the Harvard University, they have not inferior outcome there. And so we can find in Harvard University, they got the laparotomy and the 2004 before, and till 2049, they have more than 70% they perform MIT for the radical surgery already. 30% just doing the open surgery. So we know in these centers, the majority of the surgeons, they can do a good surgery in the laparoscopic surgery. And another paper is from the Spain, Barcelona. The Antonio, this doctor is also very famous. And she make this study about the radical hysterectomy, efficacy and the safety in the down of the minimal image technique. So they make a conclusion again. The MIS become the preferable surgical approach for the early stage cervical cancers is appear to be reduced morbidity without affecting oncology outcome. So we can find in the Barcelona, the university, they have the same result. And also from the Korea nationwide database, and they have sorting the data from the January 1, 2011 to the December 31st in the 2014. They get about 6,300 people, the patients, and they found have a lower, the laparoscopic surgery have a lower rate for complication, fewer transfusion, and everything you had know already. And so they have a associated with better overall survival and the good outcome. So from the Harvard, from the Barcelona, from the the Korea is quite advanced and very good skill in the laparoscopic surgery in the Koreas. They all have a better outcome for laparoscopic surgery. And furthermore, the Dr. Wang have mentioned about our data from the very beginning, from 1994. That is we doing the first one. We doing the first one in 1993, and we have the begin to take statistics in the 1994. We get the 92% of the 8 years survival, not 5 years. 8 years survival is 92%. And later on, because of some colleagues, the challenge about our data about the recently because of lake study. So we have make a statistics again from 2009 to 2014. Interestingly, we get the 100% of the survival. So in this situation, we know as the instrument improved and the technique improved, the patient's survival will increase. So it's definitely. So we can find it, the lake study, they have some problem because if you get the data, you find it's not consistent with the most or all the available data with the other current series. You should check about, you should refine it, or you should reject the hypothesis. You are not the guy to propose your data. You should turn back and you define this and they're looking for what is the mistake in your study, not just have a publish. Oh, I'm the number one. We publish the data. Everyone shocked by this data. No, it's not right. So actually, the colleagues, there is the Medland, they also have some statistics in the study in the United States. They say the survival after MIT use the cervical cancer, the survival have decreased about the 5% of years. But they also mention about the surgeon who were more experienced with open surgery, more open radical surgery, them with minimally invasive therapy. They know the baseline is not the same. That is unfair in the two competitions. So even that, the Dr. Huang also say, provide medicines is not the same as doing the surgery. The clinical trial in the surgery, the proficiencies is most important. So that is the reason we have a client. They still have another guy to have talking about that is not available in real world. So in JOG, Dr. Nam is quite famous. Actually, he learned the laparoscopic many radical surgery from some of us, and they have a very traumatic surgery skill and do a very good surgery. And so he say the survival and the recurrence is 2.2 is too low, but I think that's still possible because in our current the hearsay is that in that study in they study have an open surgery should be about 10%. They just 2.2%. But it is possible. If you are very skillful in the open surgery, yes, they're possible. But they're talking about actually in the surgeon proficiencies, in actually even in the if you want to have enough radicality, you should have the 40 to 50. And if a large tumor, then you should have at least 50 cases. So that is very fair to say that. So, so why we get a very good outcome? Because they get in one centers and they have an excellent surgeon there and just follow the standard. And when you have tailored adjuvant therapy protocol, that's very important. And so the most important, we want to change the status now. So the APAGE decided to propose the new clinical trial is so-called minimally invasive therapy versus open surgery there. So there is a 2-to-1 study, and that's all the same. At least we ask, there is the Dr. Chen Zhongping, the courtesy from the Professor Chen. You can find all this one we have showed you. It is very important in the ventral parametrium, lateral parametrium, and also the so-called dorsal parametrium sacral ligament. You should remove it all. Otherwise, you can call this a radical surgery. It's very important. They have a paracopine, parametrium, and enlarge the vaginal length. That is very important for the procedures. So I am lucky to have so many of you join our study, and the surgeons have at least 50 cases of the radical surgery. And the hospital, they have 50 per years old. They can have 200 before, and they have published a very good, excellent the data or have a quality by our committee. So they have so many famous ones. You haven't know about that. They're just a Holman and the Michael Canis, Peter Lin, the Canal and Ando and Andrew and TJ Kim and our group and the Dr. Chen group and the individual group and the Dr. Wang Gongliang also our monitor and our chairman of the safety committee and the Thailand, Alaya, India, the Shiraj. And also there are so many Dr. Chen Zhongping and Wang Xiaoping and also the Liang Ziqing, all that's a very famous the surgeon over the world. So why we need the standardizations? Because our data in the excellence center, they have a different result. So we want to have the standardization of the radical surgery. And the most important to create a better treatment model because most of the country now is not allowed to do the laparoscopic radical surgery at all. So we want to change the status because we know the minimal invasive therapy for the cervical cancer is better than the traditional surgery. No one can go back to 100 years before. Okay, so the gynecologist can follow the standard and here we can have a cooperation between the center and give them a better training. And it's always the right time to do all the right things here. Here we are lucky. Even the AGL, the president of AGL, the Julius Brown, they want to join us, and also the Peter Lin, and also the from doctor from another hospital, and the Dr. Rofer, also the support our clinical trial, and so very important for the future of the cervical cancer. Thank you.
Thanks, Dr. Li, a wonderful presentation and excellent idea. So we know the standardization is very important. So is there any question in the audience or from the website?
Do you want to have a comment? Yes, are you there? Allah, yes, okay.
Yeah, I'm there.
Yeah. Oh, you are not driving now. Yeah.
No,
yeah.
How do you know that I was driving? I was going.
You just driving. Yeah, just in your car. Okay.
So I just arrived to the hospital. I have duty today, so I start watching Tamig since 4 o'clock in the morning. Actually, now it's 11 o'clock in my country, in Jordan, and I'm really satisfied by these lectures. And always I'm support for minimal invasive surgery, Professor Lee. We luckily we have COVID to attend TAMIG this year because I missed TAMIG meeting last year. And as I said before, actually in Jordan we don't have too much cases of cervical cancer, so I will be happy to help in paperwork and to be part of mentor study as an active APAGE member. And thank you for inviting me. And waiting to see you in the notes workshop. Actually, maybe it will be postponed because our airport is closed. But as soon as we can manage to do our workshop, we will inform you, Professor.
Yes. Okay. So our the workshop in Jordan is in July, but I think
Actually we were planning in August, 19th of August, but
August.
actually
Okay.
yeah, but actually our airport is closed now.
Yes. Yes. Okay. We're waiting for. Yeah.
Sure. And thanks for your presentation and for really valuable lectures. And I did not miss anything actually. Even if while I was driving, I watched the meeting because it's so interesting.
Careful. Yeah. Yeah.
No, don't worry. I'm at hospital now.
Oh yeah. Okay. Yeah.
Okay.
Accident. Okay. Yeah.
Thank you, Professor. Thank you. And hello to all my colleagues through the web and attendees in the lecture room. And thank you again. Goodbye. Bye, Prof.
Thank you. Yes.
Thank you.
Is there any other question? So I don't want to go to bed, right?
No, Professor. It's 11 o'clock in the morning. It's morning. I have duty. I started the meeting at 4 a.m.
Okay, go. Any other question from audience or website? Now we close this session.
And we will go to the last session, last topic of this session. We are glad to invite